Okay, so for week 4, we have peripheral vascular disease in general. So that's going to be split up into the arterial disease and then venous insufficiency. So for now, let me know what you guys already know about it. So what are some risk factors that you know about in general with PVD, and then we'll go over some of the specifics. Okay, all is all correct. So smoking, definitely hypertension, obesity, diabetes. Hyperlipidemia. Yeah, sedentary. And then I'll add on age above 60 and generally atherosclerosis. Okay, cool. It's good. So PAD, peripheral arterial disease, that's going to be, by definition, just have due to atherosclerosis having a hard time perfusing down to the lower extremities. So your arteries are, I wouldn't say clogged, but slightly obstructed to the point where the blood flow cannot go down to the very lower extremities because that's the farthest point away from the heart. So that ends up leading to those your legs having a hard time getting blood flow, which leads to a few different consequences. And what do you guys know about these consequences slash manifestations? Like, just kind of list down everything you know, and we'll talk about it. And I'll add on whatever could be added on. Okay, yeah, so we'll start with arterial ulcers. It's gonna be like one of the biggest things here. So arterial ulcers, which can lead to gangrene slash necrosis. You guys mentioned amputation. That's definitely a possible consequence. Um, but that amputation, status post, yes, state. For sure, no blood flow due to excision. Yeah, so ischemia in general, you're gonna see a lot of that as well. So generalized ischemia, and that ischemia will manifest a lot as you'll have pain during activity. You will have pain during activity, and that's usually called, they might see this term on in like a test, or you might see this term on a Kaplan. Claudication, or even during rest if advanced. So this is similar. You can really, and then yeah, pale and cool. Pale cool, so pallor, and then cold. Called it mottled legs, so we can take a look at what that looks like modeling. So mottled skin kind of looks like this. So this guy right here, skin that kind of looks like that. I'm sure we've seen patients that kind of look like this as well, just that they're in clinical. Got They're like on blood thinners, or sometimes it's just bruising because of blood thinners and stuff. But Otherwise, like due to lack of perfusion there, you can see stuff like this. And the thin, shiny, hairless skin, true. Do you know why that happens? Or like why the skin can be shiny or or sorry, uh thin, hairless skin? Yeah, it's the lack of blood flow, so there's less hair growth. Yeah, so that's good. Perfect. So I include that as well. So we'll do shiny skin. We'll do decrease hair growth. I'll include maybe like shiny, scaly skin because it's not getting perfusion, so no hair growth, and the skin actually there isn't healthy skin. So decrease hair growth. Um, yeah, I'll include a few other things. So naturally, if we're having poor blood flow, oh yeah, there you go. Thank you, Nicole. Weak pulses. So that makes sense. Some of the other consequences that can occur is just because it's a perfusion issue, you're at risk of complications such as stroke, MI, and angina because of the fact that this is a disease of obstruction. So you're having some obstruction. That can lead to clot formation, blood clot formation, and then especially because these people have a lot of pain and part of their uh, thing that they do to manage their condition is to actually, try to progressively do some activity to get better. Uh, if they have some blood clots, they can move the blood clot around, and then that can make its way back. And the main issue is going to be uh, for stroke, because this is going to start as a arterial clot. So arterial clots more likely to become stroke or heart attacks. And again, in general, an obstruction, so kind of can lead to angina because of obstruction. You can honestly think of the ischemia pain and everything kind of like a, peripheral MI, peripheral angina. So like you could, for example, you can have pain during activity just like someone with angina has that pain during maybe activity, but you can even have it during rest, just like someone with unstable angina can have chest pain even when they're not doing anything. So that's the basic idea. Just straight up lack of blood flow to the peripheral. Um, and yeah, so leads to all these factors here. So here I have a list of some of the stages. You don't have to memorize it, but stage one, initially, you'll be asymptomatic. You might have some decreased pedal pulses, weakened cap refill, lack of hair on legs. As you progress, you start having pain, muscle cramping, burning, and all of this can be reproduced with the stress test. So that's something that can be done and can be seen. As you get later on, you start having that pain, that ischemia pain, even during rest. Ends up feeling numbness, dull pain, and then later on, the absolute late stage, you can have that cyanosis in the legs, the mottling, arterial ulcers, necrosis, gangrene, and you're more likely here to have amputations. So that's when they get to the really late stage. Okay. What do you guys know about arterial ulcers? What's kind of like the one of the big, I guess, defining things about them? They have yeah, they're called punch out. So they have a uh punch out, and I'll post a picture so you guys kind of get the idea. And then there's another thing that separates it from the venous ulcers that we'll talk about later. So the main difference is the lack of blood flow as opposed to the blood pooling. So what's the drainage going to be like? Yeah, so it's going to have less drainage, less to no drainage. Dry, hairless, due to lack of blood. Yeah, so all of that because you're not getting any perfusion, you're not getting any blood, can't have as much drainage if you're not, having any of that. Part of that drainage comes from it being like in the healing stages as well. Okay. Less important for testing, but it's a diagnostic is that there's such thing as an ankle brachial index. So they'll get the blood pressure basically of the lower extremities and compare that to the blood pressure of the upper extremities and do a ratio, literally the ankle systolic blood pressure over the brachial systolic blood pressure. And uh, the number that it would show would be less than 0.9, which is indicative that uh, the blood pressure of the ankles are it's basically showing that difference in that blood pressure between the legs and the upper arms, which is showing that there is a difference in perfusion level to the lower extremities, which makes sense because that's the main kind of thing that's going on there is that it's going to have a harder time getting to the legs because they're farther away from the heart as opposed to the arms. So, um, but you don't have to memorize that. So that's the good thing. But that's kind of the general idea. And then an angiogram, which is a measurement of the perfusion. So naturally, that makes sense that that's going to be one of your gold standards. Alongside maybe like the stress test can help you. It's not a definitive diagnosis, but it's something that can be done as well. The stress test. Any questions so far on what we've talked about? A specific angiogram. Let me actually see that. Usually here it would just be generalized with contrast. Just like a typical one. So you could just, it's a conventional. Okay. And then some of the treatment that can be done, mostly just similar things you would imagine with someone going through an MI is getting the balloon in there, placing a stent, getting rid of any atherosclerosis through an atherectomy, which is kind of like I think this one's the drill, like the little round drill, the spinny drill. Oh, the internet's really slow out here. But this time, there we go. So it's like a drill. It kind of gets literally drills through the atherosclerosis, all of that going on. Endarterectomy would be going in and directly like physically going in and peeling off any clot or any plaque. Well, atherectomy is a little bit less invasive, but pretty much similar things. Though instead of going into like a coronary artery, you're going into one of the like a femoral artery, for example. But the same idea still applies. It's just a different artery. Okay. And then what is some education that you guys could think of that would be important for this type of patient? So patient that has decreased blood flow to the legs has yeah, that's a really good one. So we'll go over positioning. So do not elevate the legs because that would make things worse because that no, we do that to get blood flow back to the core. So if they're having issues with blood flow to the peripheral, then it does the exact opposite. Yeah, so we'll do like a building tolerance. So walk until experiencing pain and then rest and keep trying. So over time, this will build up any tolerance. Okay. Yeah, so you want to avoid compression because that's going to be making things harder to get down there. So we're going to do avoid vasoconstriction. So avoid the cold stuff that makes you compress so cold. Overly tight clothing, tight hose, smoking. Try to avoid caffeine if possible because that is a stimulant and that will vasoconstrict. And generally try to minimize stress because cortisol can also have that impact. Avoid clipping toenails, inspect their feet for legs for ulcers, avoid alcohol. All of these are good stuff. So let's see, we can add just being careful, inspection of the feet and legs. Yeah, so we can do inspection. It can include like inspecting for ulcers, being careful when performing ADLs involving feet. So that would be things like clipping your toenails, etc. Avoiding alcohol in general. In general, that's probably a good idea. Let me see if there's what else do we have here? Yeah, so avoid. Yeah, something I guess that's interesting here is that we said that we want to avoid the cold, but you also want to be careful with um, direct application of heat because another thing that kind of goes on is that they'll have decreased sensitivity to that limb. So sensitivity to limb is reduced. So you can still use like a warm compress as long as it's covered in like a towel or something. But as long as it's not like direct application of heat. Similar to, I guess, people with diabetes, you want to be careful when they're, because if they have decreased sensitivity, they might not be able to tell when the bath water is too hot, for example. So a lot of this, is this what we're trying to avoid? Or is that venous insufficiency? I'm not sure if I've heard that one. Let me see. That would make sense though, yeah, to avoid crossing legs. Do not elevate. Another one to put is dangling to bring the blood back to the legs. And then something that happens, it will get really red. That's called a dependent mover. If you hear that, that's what that means. And yes, avoid crossing legs because here, if they cross their legs, it would also impedes the blood flow. Impedes the blood flow. So pretty much anything that would cause blood flow to not make it down to the legs is something that you want to really kind of work on. So every once in a while, especially if they're on the bed, it's kind of hard to get them to have the blood kind of flow, even if they're lying flat. So you'll have them sit for a bit to try to get some of the blood flow back because you want to make sure that their legs are getting some perfusion. Okay. What about medications that you can see someone with this having, and you can take into account everything we kind of talked about for the manifestations, uh, and kind of some of the consequences as well. So yeah, I like that, like medication adherence. I like that. Medication adherence for things such as um, hyperlipidemia, diabetes, hypertension meds. Antiplatelets is going to be a really big one. So antiplatelets and anticoagulants. So some examples, yeah, aspirin, Plavix. Those are some examples of those. We'll put a hold parameter here. When do you usually hold antiplatelets? Silostazole, that one's used for, that's a vasodilator, so that one's used for some of the claudication pain. So we can include vasodilators. This one's also known as Platal, used for claudication pain. Sure. So, bleeding. What about a platelet count? So, like typically, if the platelet is too low, you don't want to give the antiplatelets and give them thrombocytopenia. So, what would be the value where you would start to hold it? These are good guesses. So, 150 would be the lower end of normal, but funnily enough, usually it gets held under 100. So under 100 is when it's considered more causing physiological issues now, possible like higher risk of bleeding. So you might have also seen like platelets under 100 for, and when I say 100, I mean 100,000. Just because like the on the blood labs, they will, the platelets will be shortened to just like a three-letter value usually. So you'll see like platelets 250, but that means 250,000. So when I say 100, I mean 100,000. But yeah, under 100. So platelets under 100. Similar, you might have heard of heparin-induced thrombocytopenia. So um, people that are on heparin, you want to hold it if their platelets are under 100, even though it's true that for the most part, you look at the APTT, that one's more so for the IV heparin than like a subcute heparin. The subcute heparin, you can give that without having to get the complex coagulation panels, you can just go off the platelets as long as the platelets are above 100, the heparin is fine. So same thing. As long as the platelets are above 100,000 platelet, not aspirin and Plavix are fine. And then for the anticoagulants, what are some examples of those that you guys can think of? And Plavix is clopidogrel, just so clopidogrel. So what's like the most common anticoagulants you guys see? So people that have had a DVT, they might be on previous DVT or a pulmonary embolism, they could be on these meds. You see this a lot in the hospitals. I just talked about it. So what's another anticoagulant that you see? Heparin, Coumadin. Yeah, so we'll see Coumadin, aka warfarin. Okay, and then heparin. And I'll include Lovenox. Lovenox is a high molecular, or is it low molecular? Low molecular heparin. So in hospital, it's usually subcute. And then one that is more common on more people now, but it is expensive, and that's Eliquis. Okay, so for Eliquis and Coumadin, what do you monitor on the coagulation labs? Yeah, PT/INR, and then also platelets. So same idea, hold if under 100, but yeah, you're also going over this. Does anyone know the difference? Like what's the difference between the antiplatelets and anticoagulants, kind of in practice, I suppose, for the most part. So when do you typically see dual antiplatelet therapy or just like baby aspirin versus when do you see anticoagulants? Yeah, during surgical revascularization. I guess technically you guys haven't gone over it, huh? What about for like who else can take baby aspirin? Like you guys have seen in clinical. Like someone that's like a previous history of some of like two major events, like a stroke. Yeah, so stroke and then MI, exactly. Stroke and MI. So you notice those two things, those come from arterial clots. So antiplatelets are a bit more effective at preventing arterial clots. And then anticoagulants, what do you typically see like heparin subcute? What's the use case for? Like what are you trying to prevent with the heparin subcute? DVT, exactly. So DVT, if you guys recall the pathophysiology of that, that is actually a venous clot. So a clot that is created venous like on the in the veins and then travels up. So Eliquis, very common after very common after like a pulmonary embolism. So they'll be on Eliquis to try to prevent more of those from happening. Coumadin, same thing. So for the most part, the anticoagulants are more effective at preventing venous clots, which is why you'll see people on heparin subcute for DVT. but they won't put them on like baby aspirin for that. They'll have baby aspirin or uh, if they've had like a history of like stroke or MI or for prevention. So that's kind of the main difference. Although you'll see some where like um where it's kind of like a mixed case, but that's the general idea. So another instance, so you'll see like aspirin for post someone that's had a stroke in the past, someone that's had an MI in the past, someone that has stroke probably on dual antiplatelet, um, someone with AFib, someone with AFib can be on baby aspirin too. That one's interesting because that one is usually they'll be on warfarin as well for prevention of clots in general. Uh, because with AFib you can have just formation of clots in general because of the weakened beats essentially. Like you have like those extra fast beats that are not very effective that will not push anything through, so you'll have clots forming. Um, so that one's a little bit where it doesn't quite follow the rule, but that one just because it's kind of like a systemic thing because the poor those individual like poor beats kind of affects the whole body, so it's a little bit of both on that front. But that's kind of like the general idea. And then we talked about vasodilators and then compliance with these meds, so that are usually antihypertensives such as beta blockers. Such as the prills, so ACE inhibitors, etc. And if somebody has an active clot, we can try heparin IV drip, RTPA, which is a clot buster, or a PVI, which is just a percutaneous vascular intervention. So that is when they percutaneous spelled that wrong for sure. That is when they kind of go in and do the interventions that I mentioned over here. The angioplasty, the stents, getting rid of the clot directly, or getting rid of trying to reperfuse the area by getting rid of the atherosclerosis. Perfuse. And then we talked about with IV heparin, you want to monitor the APTT and then still platelet. And key note, because this is something that people have like a misconception of. IV heparin is there to prevent the continued growth of any clot, but it will not destroy the clot, as opposed to RTPA, which will directly cause the clot to kind of dissipate. Okay. Any questions on peripheral arterial disease so far? I'll focus more on the arterial ulcers a little bit further down. I have a direct comparison chart that will help for that. Okay. So then the peripheral venous insufficiency or chronic venous insufficiency, this one's pretty much the opposite. Well, it's kind of an opposite problem. It's instead of the arteries having a hard time getting blood down, it's going to be that there is a difficulty with the pooling of the blood. So the blood makes it down there and then it has a hard time getting back up through the veins. So a struggle for the blood to get back to the heart, so it pools into the legs. Um, what are some manifestations? So if you guys could do me a favor, if you guys could list any manifestations that you guys could think of for the venous insufficiency, and then at the same time also kind of just write down uh, Oops, sorry, I disconnected. Okay, so if you guys could list down any manifestations you guys can think of for someone that is having blood pooling in their legs, and then we kind of know that DVT is going to be one of the main complications of someone having difficulty getting blood flow through. So if you guys could also list anything that you guys can think of for DVT, so anything that you do not want to do when there is a active DVT, uh, and then anything that like what is like signs and symptoms of DVT. So and I'm gonna go. I'll be right back in like a minute or two, so you guys could just start listing stuff. That'd be appreciated. Okay, sorry about that. Let's see. Let's see what we got here. Let's see, don't ambulative DVT. The first house try it. I haven't heard that one in a while. Okay, let's see. Just gonna go through everything. Just start from the top. Edema, the red brown, yep, pigmentation, swelling, pain, lower extremities, venous stasis ulcers, yep. For the treatment, yes. So for the treatment, you're gonna wanna elevate legs. Warm and swollen versus PAD being cold. True. Like warm slash swelling. Yeah, because you have all that blood flow, so it's actually gonna be you're gonna have some actual blood flow, so warmthness and supposed to being cold from the lack of perfusion. You're gonna want to do for prevention, compression. Okay. And then what else do we got here? Oh, maybe some of the signs and symptoms of a DVT. You're gonna have sudden unilateral swelling, so as well as calf, maybe groin, tenderness and pain. That's kind of what tenderness means, but yeah. The hardening along the vessel, so the vessel itself might be hard from the fact that there's obstruction. The vessel, you might have like kind of like with infiltration, you have the red hard vein. You might have some vessels that are really hard, red and warm. And yes, we do not want to massage a DVT. We don't want to elevate a DVT, and we don't want to ambulate or compress a DVT. Just because all of these can lead to it being moved and then kind of making its way back up to the lungs. Sorry, disconnected again. All right, let me try again. Okay. Did you ask a question, Eric? All I see is that all I see is a question mark. Oh no, no. That's this one's do not. So the idea is if you elevate it, you are kind of making it easier for the clot to kind of go back up. So that's why you don't elevate, but to prevent it, you do elevate. So it's kind of like the preventions for DVT is to get blood flow back to the core. But when you have an active DVT, you have a clot, you don't want the perfusion. You basically want to prevent the clot from going back to the core. So you're doing the exact opposite of what you were doing to prevent it, if that makes sense. So that's why you don't massage a DVT, but when you're trying to prevent it, you have compression. You can have like SEDs that are basically giving a constant massaging pressure. Um, at least when I was in school, we were taught not to elevate. Just kind of keep it there. Do not disturb it. I can check to see what current evidence-based practice is, though. Okay. So I'm looking at it and it looks like yeah, that's for general that's for general uh what's the word? That's for general like perfusion. So you want to elevate for venous because it lets the blood come back to the core. For DVT, from what I'm looking at here, it looks like the current evidence-based practice suggests that elevating does not increase the risk of the clot traveling, but it does help with the swelling. So as opposed to, I guess, not sure when that was updated. I do know my curriculum was very old, so I'm not sure when that came into effect, but I guess if but the current evidence-based practice is that elevating is fine actually for DVT. So I'll remove it, but I'm not sure because Jim, Mr. Robbins is probably just I don't know. I'm not sure how he's gonna do the testing if that gets asked. I would just I would just ask him directly, I guess, if possible. But I guess your test is on Monday, so I'm not sure. Did he directly mention any of it, or I guess I'm not sure if it was even Mr. Robbins, if it was Salazar. Did any of them directly mention it at all about that in particular? Okay. But yeah, that seems to be the evidence-based practice that elevation of DBT is actually not going to increase the risk of not going to increase the risk of the clot moving. Okay, fair enough. That's why keeping up with all this stuff is important, I guess. As for hospital policy, depending on the hospital, they might not, they might still tell you not to elevate. It depends on kind of like your policy, I guess. So if you are, I mean, I guess if you're a clinical, you kind of want to probably want to know. Although granted, if someone has an active DBT, like it just happens, like when you're there, you probably want to get the nurse as well. And then they'll tell you kind of where to go from there. But yeah, I guess it's important to know what the hospital policy is for that, just so you're not liable in case something happens. Like you were just doing the hospital policy. Okay, and then here I have just some things for like assessment. So, how much detail did they go over heparin drips with you guys, if at all? I think it might be more later, but I'll just kind of provide the basic. We gotta do calculations? Oh, cool. Okay. All right. So I'll just post the stuff here. So with an active EBT, you're going to be assessing for perfusion. So pulses, level of consciousness, and then oxygenation because a DVT can become a pulmonary embolism. So seeing if they become suddenly, suddenly short of breath, for example, suddenly have tachycardia, and then an heparin IV drip. Your PTT is typically around 25 to 40, and your goal is typically around 2 times the normal. And you guys have to do calculations now, huh? Okay, that's cool. I don't think I have time to go over some of those problems, but if we do somehow, uh, Just show me the problem and we'll work through it. Okay. Just so we have enough time, I'll just start going a little bit faster. So for prevention of DVT, elevate the legs, compression and exercise. And if you really want to, you can make this one as elastic compression hose. And you guys know it also means SCDs, just so you have three E's if you want to. Uh, three E's. All right. No, SCDs, Ted hose. Have you guys ever? Ted hose is literally looks like stocking. This is literally a stocking. Just a really highly compressed stocking. And SCDs is the machine that gets velcroed around their leg and has a machine pump. This is a Ted hose, so it's literally just a like a really strong compression stocking. Okay, and then just to kind of save a little bit of time. Just I'll go over the stasis ulcers and just post kind of like their general presentation so we can take a look at some pictures. So venous ulcer, let's see a good one. Very typically on the ankle, more common on the ankle, have a irregular shape. So you see this is kind of like going all the way like this. There's granulation tissue that you can see. And then typically it'll be very oozy, very weepy because there's so much blood flow here that there's a lot of it's gonna be a lot of drainage, and it'll typically be a reddish brown color as you can see here. Okay, and probably go into a bit more detail when I have like the direct comparison chart. But right here, just best practice for generally, all these people are gonna be on anticoagulants or antiplatelets, so monitoring for bleeding is really important for that. The IM injection thing is just due to bleeding risk. Shaving, again, due to bleeding risk, so they can have electric razors. It's a little bit safer. Soft toothbrushes, so again, bleeding from the gums. Monitor the labs, so that would involve the PT-INR, the APTT, the platelet. Um, and then patient teaching. Something that I think they talk about quite a lot is the fact that vitamin K and Coumadin are kind of like opposites. So the Coumadin, if you have a big intake of vitamin K, it can inactivate the Coumadin. So that is why one of the important patient teachings is basically just maintain a consistent vitamin K intake. So if you're eating a salad, if you're eating a salad daily, maybe decrease the amount of vitamin K foods you're having, but you don't have to completely get rid of it. You just have to be consistent with it. Because at the end of the day, they're going off the blood lab levels. So if you're consistently having the same amount of vitamin K rich foods, then that becomes your baseline essentially. Disconnected me. So yeah, so just consistency is key. Titration of the medication will occur. As long as it's consistent, it's fine. As long as it's not a sudden influx, it'll be okay. the antidote for heparin is protamine sulfate. So if you see that somewhere, like on Kaplan or something, there's the answer. So this is basically just review at this point. So lifestyle modifications would be like exercise, improving your diet, because a lot of this has to do with things such as hypertension, diabetes. Oh, repeat for in regards to Coumadin, or I think I probably disconnected mid-sentence if I had to take a guess. Nicole, for repeat what? Hello. Well, if you want me to repeat something, can you type it? Can you guys still hear me? Oh wow, it must have lagged so much I couldn't see the comments being posted. Oh, okay. The comment you're referring to is actually about heparin. So protamine sulfate is the antidote for heparin. Or what? It's just antidote is by protamine sulfate. So if you see this on a Kaplan or something, that's the if they ever ask you like what's the antidote for heparin on like a Kaplan question or something, you're not really gonna get questions like that on the nursing school test. But on Kaplan or something like a easy question, it would just be like ABCD, what's the antidote? There you go. It'd be protamine sulfate. And then the rest of this is just review. So exercising, improving your diet, no smoking, less caffeine and alcohol. All of that relates to our risk factors. Anticoagulants, watch out for bleeding. Makes sense. It's kind of all stuff that we can kind of just use intuition for. Health promotion, same kind of stuff. If you have CVI, the venous insufficiency, you want to elevate the legs, keep them elevated for a bit. Try not to, I guess also do not cross the legs from that. From what I see, crossing the legs is relevant for both conditions, but um yeah, this is general. And then here is kind of a direct compare and contrast. This is probably going to be the most helpful thing, honestly, here is because having them side by side really helps. So difference between the different types of ulcers. So for example, arterial ulcers are going to have a more punched out appearance. So we can take a look at a arterial ulcer. Yeah, stuff like that, like you can see, especially this one. This one's pretty typical. Kind of just look like that. You notice that it's also pretty regular for the most part. So a arterial ulcer is more circular and can have some irregularity, but for the most part, it's circular. It's like a punch out. Literally, like they took a hole puncher and just boom, boom. Uh, because of the lack of blood flow, it's more likely to be have a lot of pallor, maybe even be necrosed because of just complete lack of blood flow. the arterial ulcers can be more deep as opposed to the venous ulcers, which are more superficial. The arterial ulcers would be very painful because it kind of also comes with that lack of blood flow pain. While venous ulcers, they do have blood there, so the pain isn't as bad in terms of like ischemic pain. But when it's really deep, really progressed, it can be painful. Arterial ulcers, as you can see here, are more likely like bottom of the feet, top of the foot, usually close to the like the bone heel or just pressure areas, while the venous ulcers are more likely on the ankle. And then here's one for general insufficiency. So arterial insufficiency, aching or sharp from pain. Aching or sharp from exercise. Venous insufficiency is more of a aching and cramping. Uh, helps to have some elevation. Definitely helps to have some activity, as opposed to arterial ulcers, which is relieved by rest. Arterial insufficiency, you're having a lack of blood flow down there, so the pulses are going to be a lot less, weaker. Venous insufficiency, you're having proper blood flow down there, so the pulses are going to be fine. Because of the lack of blood flow, arterial insufficiency, cold, dry, shiny, hairless. It's gonna be pale. It's gonna be red when dangling. Venous insufficiency in general is just gonna be more brownish color. It's gonna be warm because you still have blood flow. Bit thicker, uh, especially due to the edema. Just you have it pooling down there, so it can be swollen. While arterial insufficiency is definitely not gonna have any edema because there's just not any blood flow, not good enough perfusion there. And then I have a little bit here on, I have some pictures here. You can just general leg ulcers, venous ulcer. See, it's around the ankle. It has brown discoloration, uneven. Arterial ulcer, you see here, kind of like a punch out, and then some other stuff that came with the picture. But how much, I'm not sure how much you guys go in deep into amputation, but for the most part, the main thing that you have to know um, is that there's going to be a lot of potential nerve pain. So something like gabapentin can be given for that. Pregabalin can also be done for nerve pain. Uh, you want to put a little some pressure on the stump just to kind of can help with the kind of the getting the perfusion there and making sure it's not going to reopen up. Because I have seen some patients that they get amputations and then you can see that the end part of the stump is already starting to necrose again. So they might have to amputate more. And then, of course, lost a limb, so psychosocial is important. For the perfusion, if they, PAD, this is before any amputation, the gabapentin. It's a, it's used for, yeah. So gabapentin is used for seizures, but it's also used for nerve pain, or it's also used for anxiety as well. But you'll see it often for nerve pain or anxiety, or seizures, I guess. For seizures, you might see more Keppra, but gabapentin for nerve pain. And then for the perfusion, if they have a below the knee injury, oh sorry, below the knee amputation, you can get the pulse behind the back of the knee. If they have an above the knee amputation, you need to get the femoral instead to check for the CMS. You want to assess for necrosis, like I mentioned, it can occur with like the stump. Just the Even though you got rid of like the very lower end, the perfusion to there is still not good enough because now it has to still make it down there, which is it's still on the lower end of the body. But if someone has like PAD, for example, But then also now it needs blood flow to heal. So if there's already a decreased blood flow, even the recovery part after the amputation might suck and it might require another amputation. So for that purpose, it's possible that they do an above the knee amputation, even if the issues are more like around like the lower leg of the foot. Like even if it looks like you could get away with a below knee amputation, sometimes they'll just do more. They'll do more just because they'll end up having a better outcome, depending on how badly progressed it is. And then naturally, you just cut something off, so pain and infection and changing the dressing. Some of the complications here are listed. All of these kind of make sense with what you've got. You just got something cut off, so there's healing going on, there's possible clotting going on. It's open, so possible infection going on. And then here's just a picture like I showed, and then here's another one that shows, yeah, I don't know if this is from Simple Nursing, but I was given the picture, and this helps also. It's like a comparison guide as well, and it does have the same thing as the that Angela was mentioning here, the A versus V. That's a really good one. Okay. I'm not sure if we'll get time to do week 5, if I'm being honest, but I'll try. Heart failure. Honestly, I'll try to just talk through it, as otherwise I don't think we're gonna have time because it's a lot of medications. So let's just see what we got. So for so for all this, the main thing to keep in mind is going to be kind of the differences between um, and for diagnostics and labs, you can get an echocardiogram. That's going to be your main thing here. Maybe an angiogram. That's the echocardiogram is going to be your main thing here. Left-sided heart failure. So the main thing is like to tell the part left-sided versus right-sided. Usually L for left-sided, you want to think about because it affects the lungs, the complications involve the lungs. So left-sided equals lungs, you can think of, or lung complication, lung congestion. Let's do that. And then right-sided, the R for rest of body congestion. For me, that helps me remember that. So with left-sided, you're going to have things such as pulmonary edema, crackles in the lungs, shortness of breath, coughing. So when somebody has heart failure in general, you want to assess the lungs because they could be kind of crackly. They'll need diuretics, for example. I'm sure you guys have encountered a lot of heart failure in clinical, which is probably why they don't teach it early because they feel like you'll just learn it naturally. But uh, that's like the main thing. So these people are gonna have higher blood pressure. They're gonna have probably fluid in their lungs, need diuretics, need prills, ACE inhibitors, things like that. And your main complication for left-sided heart failure is going to be uh, pulmonary edema, drowning basically in your own body. As for right-sided heart failure, it's going to be congestion of the rest of the body. But one of the other complications of um, right-sided heart failure is left-sided heart failure. Because if the right side of the heart is backing up, that means there's not enough going to the left side. So eventually that one also backs up. And um, or technically actually it's just the opposite. Like right-sided heart failure can lead into left-sided heart failure, and kind of vice versa as well. So usually you'll see on like the charting, they won't really specify versus they won't really differentiate between which one it is. Usually it will just say heart failure, and then that's pretty much all you get. And the same assessments kind of still apply. Are they swollen? They probably are swollen if they're in the hospital, like inpatient hospital. Do they have pulmonary edema? Because left-sided heart failure can become right-sided heart failure, and more commonly, left-sided heart failure can become right-sided heart failure, and then right-sided heart failure can also lead to left-sided heart failure, just because, the whole heart has to work with itself. So if one side starts having issues, the other side's going to have issues. But that's the general idea. So you're going to have just generalized body swelling. The main things you'll see is peripheral edema and maybe JVD. So that would be let's see, JVD, the enlarged jugular, this one right here. This one's really bad. This one's pretty gnarly too. You can see how it is though, right here, especially here or right here. Okay. So the management from non-pharmacological, you're going to have a restriction of fluid and salt. If they're swollen, you don't want them to swell up more. Salt will make them swell up more. So that's that. Better the bed up because if they're having pulmonary issues, you want to make sure that their oxygenation's good. If they're having lung congestion, then turn cough and deep breathing and IS can be helpful for making sure the lungs are working fine or expanding the lungs as much as we can. Daily weights, so using the bed weight and then eyes and O's because you want to assess if they are too like they're having a really rapid decline. So usually over 2 to 3 pounds in a day or 5 pounds in a week is cause for concern. And then technically O2 is pharmacological, but we'll just include O2 if needed. O2 support, maybe they'll need to be on a nasal cannula or something. For the pharmacological, this is kind of a mnemonic, not really, but A for ACE inhibitors or ARBs. So the main things to watch out for this one is, of course, you're going to be monitoring the BP because this one affects the BP. You're going to be BP and potassium. The lisinoprils, the aldoprils, the sartans, they are going to affect the potassium, increased potassium because of the way they affect the RAS system. So if you recall from, actually, I'm not sure if it was this class or not, but if you recall from the RAS system, the aldosterone, that one has the purpose of dumping dumping potassium and keeping salt and therefore also fluid. So if you are preventing the dumping of potassium, you are kind of bulking it up and you're going to have the opposite problem. So that's why the ACE inhibitors have the potential for increased potassium. And then you're going to monitor the BP, hypotension. That's self-explanatory, but I'll put it there for clarity. Um, Main thing to also note here is possible cough. That's a side effect of ACE inhibitors. And then if it's really that bad, like the nagging cough, nagging dry cough, if it's really that bad, then you can switch to ARBs. Usually first line is going to be April. I'll make it a considerations tab. Angioedema can occur. So that would be, you want to take a look. It's going to show a really swollen tongue, swollen lips. Occur, and then you want to DC the med if that happens. And then examples, like I mentioned, the lisinopril and losartan are the main ones. Okay. The B stands for beta blocker. So this one you're going to be monitoring the BP and heart rate. Lowers both. Okay. Another thing to keep in mind is can affect those with respiratory conditions. So, for example, if they have asthma, some of the beta blockers are not cardiac selective, meaning that they will affect the lungs as well. So, for example, um, so examples of these is going to include atenolol, carvedilol, metoprolol, propranolol. So the cardiac selective one is the main ones that are cardiac selective. Top of my head is metoprolol and atenolol. The other ones can affect the respirations and respiratory. So the other ones can have an effect. So they're not as recommended for people with asthma, for example, because it can constrict the it can cause constriction of the lungs, which would be bad if someone has asthma, which is why uh, are cardiac selective. They would probably rather be on metoprolol because that's cardiac selective, so it's not going to affect their lungs. And in general, metoprolol is pretty common to begin with. I see metoprolol, carvedilol, and propranolol the most, but I see a lot of propranolol for anxiety, to be fair. But I work at a psych facility, so it makes sense. Uh, C for cardiac, not cardiac, sorry. Calcium channel blockers. So this one also going to be lowering the BP and possibly the heart rate, depending on the type of med the type of cardiac channel calcium channel blocker. So the dipines, like for example, lodipine will mainly lower BP. And then there's other ones like diltiazem and verapamil. Diltiazem, verapamil can also lower heart rate. Just they have different effects. They both are calcium channel blockers, but they have different effects on the vessels. So amlodipine will mainly lower the blood pressure. Diltiazem, verapamil can will lower blood pressure and heart rate. Uh, so You'll see cardizem a bit. It can be used for long-term management of blood pressure, extended release cardizem, or you'll also see it the fast release for someone that maybe is having AFib with RVR. So a really rapid, like 150 plus heart rate AFib, they will do diltiazem, IV diltiazem. Uh, yeah, it's kind of that. The D and ABC DDD is diuretics. So that includes furosemide or Lasix. We know this can lower the BP. We know that this can lower BP and potassium, which is why it's often paired with lisinopril because this one makes it potassium go up, this one makes it go down, so they kind of balance each other out to some degree. This one's the loop diuretic. Spironolactone. This one's a potassium sparing diuretic. Diuretic. So that means you're going to lower BP and you want to monitor K. Uh, can end up with hyperkalemia by accident. And then a common one is hydrochlorothiazide. Hydrochlorothiazide. Any of the meds that end in thiazide. These are going to be essentially the same thing as loop diuretics. They don't affect the loop of Henle, but same idea, lower BP and potassium. Those are the main things you're going to see. I spelled spironolactone really wrong. Spironolactone. Yeah, so I see a lot of Lasix, very common. I see a lot of actually I don't see spironolactone often in medical, but I see it in psych because it can be used for acne or HRT. So there's a lot of people that come in that have spironolactone and like progesterone at the same time. It was like, okay, that one helps with that. Helps with acne, helps with some of the symptoms of HRT management. Because otherwise, I didn't really see spironolactone very often at all. I saw almost entirely Lasix, but yeah, that's for me. Then another one is digoxin. This one will decrease heart rate, increase contraction strength. Main thing to know about digoxin is that you need to assess for toxicity. So I'll just copy paste that part. Boom. Anything more than 2 is toxic. And some of the signs of toxicity, and I really recommend that you kind of have that good idea about it just because it will, there we go. Just because it will come up. You'll see the toxicity questions come up for the Joxin on like Kaplan. I definitely saw it on I think I saw it on the NCLEX too. It just comes up a lot. So yellow, green halos, blurry vision, trouble kind of seeing things, nausea, vomiting. All of those are signs of digoxin toxicity. And then the potassium can make things worse. So you want to make sure that the potassium levels are good because low potassium can increase the risk of toxicity. And the last D is for vasodilators, so nitroglycerin, for example, and hydralazine, which is lower BP. So sometimes the person could be on PO hydralazine. In the hospital, you probably see hydralazine more like a IV push med for like really high blood pressure. Uh, yeah, this part will just be a copy paste here, to be honest, just so we can get through it. And we'll try to squeeze week 5 as best as we can. Patient education, cardiac rehab. So this will be like if someone has a MI, they will try to see if they have any leftover complications, such as like arrhythmias developing, if they need to be put on any antiarrhythmics. If it's really bad, maybe they need to be sent home with a life vest. So it's going to be like it says here, a wearable defibrillator. It's also going to be there to assess how their heart has been going. So maybe they come back. They have to come back, and then they're going to kind of be assessing like this is how your heart rhythms were. Maybe you need a implantable defibrillator so that you constantly have something that defibrillates you in case something happens. Or maybe you're okay with your antiarrhythmic. Main thing to focus on is really the report. Like, what are you reporting when you're home? It's the rapid weight gain. You really have to be careful of swelling. Something you'll see on test is like they'll put something, it's kind of vaguish, but they'll put like, oh, my shoes don't fit me anymore, or my ring doesn't fit me anymore. That's supposed to be a sign of swelling. They're supposed to interpret that as possibly worsening of heart failure signs and symptoms. Signs and symptoms. During cardiac rehab, avoiding things such as cough medication, antacids, and NSAIDs, mainly because they affect the kidneys and perfusion. When you have instances of poor perfusion, it affects the kidneys. So just trying to keep that safe. And then here's like an actual, kind of like an actual guide. Oh, and then also NSAIDs actually also cause swelling, possible swelling. So NSAIDs are technically to be avoided. Um, NSAIDs can cause edema, swelling. So avoiding them in a patient with heart failure is relevant if possible. Um, yeah, but this picture also has a lot of really good information, like daily salt, typically restricted to under 2 grams of salt. Try to have 2 liters of fluid. If it's you're having an active exacerbation, you'll see in the hospital they'll do fluid restrictions. So maybe they'll have them at 1,000 mLs or 1.2 liters, 1.5 liters, depending on what it is, how bad it is. Yeah, I know that was really fast, but I hope this is mostly review based off like your own learning from clinical. Is there any questions on heart failure that I haven't talked about or you're confused about? Any clarification on medication or anything? And let me get around to saving this stuff so I can give to you guys. And then I also have a questions for you guys to kind of work on your own time. It has the answers. The thing I'm going to give you guys also has the answers posted. Where do I want it? I guess we'll have it here. So how many questions that I got for you? Like 14 questions that you guys can use to practice. And hopefully, I'm gonna start uploading it now. Hopefully, it doesn't take too long because my internet at the time is not the best. Okay, in the meantime, I'll move on to week 5. So, because I'm gonna focus mostly on pulmonary embolism, and then pneumonia and COPD, we'll figure it out if we have time. Pulmonary embolism, usually a complication of DVT. Um, that's let's see. Yeah, usually a complication of DVT. It, it's just anytime there's air, blood, clot, fat from another part of the body gets stuck in the big pulmonary vessel, it's going to lead to essentially an infarction in that area. So obstruction, lack of blood flows, you're going to have difficulty breathing. You're going to have pain in that area. And yeah, anytime there's like major ischemia in a major vessel, that's going to be bad. So pulmonary embolism is essentially like an MI for your big pulmonary vessels. But it does have to get to like a major one. So something that's interesting is that your lungs have a lot of capillaries. So sometimes you have like like a little small clot from your legs that make it up to the lungs, and it just gets caught in a capillary or gets caught in a small vessel. And yes, that small vessel will die, but you have a lot of them, and you can revascularize those pretty easily. So your lungs are almost like a net for catching small clots and preventing them from making it back to the other side of the heart where that clot could then be pushed out to the brain or just get stuck in like a valve or something or something like that. So your lungs are almost like a little safety net, but when that clot makes it all the way through and continues growing through the vessels and then gets stuck in a large vessel, that's when you really have a problem. So some of the risk factors, and I want you guys to really focus in on the risk factors, include things like immobility. So a lot of the things here are things that affect your risk of DVT. So anything that affects your general risk of DVT or clotting in general is something for you to keep note of. So immobility is big. So bedbound patients, DVT is something that's really common, hence why it's very routine for us to do anticoagulants. Someone that is post-op, their body has just basically gotten essentially gotten an injury, so their body's trying to clot it up. So that can happen. Someone that's having a long flight is very immobile. I think you probably mentioned something to that extent during the audio. Oral contraceptives are going to also cause risk factors for clotting because when someone is pregnant, their body is in a hypercoagulable state, so their body makes clots easier because the idea is if you're pregnant and then you suddenly give birth, you just have a large amount of blood loss that is going to need to be able to be clotted up super fast. So contraceptives, kind of mirroring the effects of pregnancy, will lead to higher risk of clotting. A PICC line, if we were, I don't know if it was this class that we talked about the central lines or not. But the PICC line, someone with a PICC line has a higher risk of having a clot in their arm. So something that should be done is measuring the arm circumference, and or else you can get a clot, and that's a venous clot. So then the venous clot can make it back to the heart and then become a pulmonary embolism. Smoking is just always going to be a risk factor for most things, especially anything involving perfusion. Removal of a central line, when you remove a central line and it's done with improper technique, it's possible to get an air embolism. So then that's can cause a pulmonary embolism if it's a bunch of air. Chemotherapy can also lead to it. Same kind of idea. Fat embolism, long bone fractures like a femur or something, that can lead to fat being dislodged and making it up. So that would be the fat embolism, which is a type of pulmonary embolism. Generally being hemoconcentrated, so risk factors for clotting in general, dehydration, diabetes, and then AFib can also be a possible one, but I would say it's less likely, but it's still possible because AFib is more likely to cause arterial clots because usually the lack of fibrillation, the lack of not fibrillation, the lack of strong contractions because you're going to have those fast but ineffective contractions can lead to clot formation, mostly on the left side of the heart. And then when those clots are forming in the left side of the heart, they go to the brain and uh, arterial, like into the arterial. But you're also going to have weakening in the right side of the heart as well. So you could have a clot just directly get formed from the heart, make it to the lungs that way. So that's the main stuff to keep in mind. For the manifestations, you're going to have a lot of sudden chest pain, shortness of breath, feeling of impending doom, fast heart rate, fast breathing. So kind of vague symptoms, but someone has an active DBT and they're having all these symptoms, you can kind of make the assumption that they're having a pulmonary embolism. But this, like I said, it's kind of vague symptoms. So like this kind of symptoms can also be indicative of like a pneumonia or something like that. Other things that could happen is lack of O2. If you're having an infarction in your pulmonary vessels, you're also going to have an impedance in your exchange of O2 because your body needs perfusion, not just ventilation, to be able to get O2 in the body. So lack of O2, hypoxia. Initially, you can have hypertension just because of the sudden stop in blood flow, but then as your body deteriorates down, you have hypotension. There's a collapse of alveoli, so crackles, and then due to the blood clot in the lungs, you could start coughing up blood as well. And here's a picture that I like these pictures. There's just a way you might just remember it a little bit better. So here you can see the venous highway. So it's kind of that a lot of these originate from mostly from venous clots or pretty much exclusively from venous clots because the arterial side goes to the body and has to go all the way around the body back to the right side of the heart to then get to the lungs, while venous clots go back to the right side of the heart and then go to the lungs. So um they skip a large part of the way there. But you can kind of see it's like a sharp stabbing pain in the chest. You can see here it's showing you it's like, oh, this is the um clot going up back up to the lungs. Hemoptysis, they're coughing up blood, fast heart rate, lack of O2, sad O2, difficulty breathing, uh, etc. And it's showing you here the heparin drip because that is something that's going to be used as a management. So then for assessment, we're going to have lung assessments, which makes sense because this is pulmonary. So things like lung sounds, we mentioned that you can have crackles in the lungs, chest pain. So when somebody has respiratory issues, you're going to want to put the head of the bed up, provide O2, call a rapid if you feel like they're decompensating, non-rebreather if you feel like you need to, or ambubag if you feel like you need to. Maybe they can get intubated. So if this is all going down, uh, head of the bed up, call a rapid, and then in that time put a nasal cannula on, and then see where that goes from there. Right-sided heart failure. Uh, right side of the heart leads to the lungs. So if the right side of the heart is backing up, that usually is due to that will cause or lead to or be caused by pulmonary hypertension. So a lot of pressure building up in the lungs that causes stuff to get backed up to the right side of the heart. Because of that pulmonary hypertension, you can have pulmonary embolism just from obstruction due to just the high blood pressure and the prevalence of clots that way. Arrhythmias, like we talked about, AFib can lead to it. And then and then also the pulmonary embolism can lead to arrhythmias. And then also vice versa. The pulmonary embolism could lead to especially if it leads to long-term complications, right-sided heart failure, because it could lead to complication with the lungs. So if you have pulmonary embolism, that can lead to pulmonary hypertension due to like a long-term complication of having that infarction happen. And then due to the extra pressure in the lungs, the right side of the heart is struggling to get blood through. So you have right-sided heart failure that way, which is why it can sometimes it's called cor pulmonale, cor being Latin for heart, pulmonale meaning related to the lungs. So that's that where that relationship lies. Um, a PE could also lead to cardiogenic shock entirely. So pump failure. Your heart is just straight up struggling to pump because of that massive infarction. And sometimes, I don't know if you've seen, sometimes you see how like people will post pictures of like a pulmonary embolism, like after they took it out. 'Cause they could also surgically remove it. Or sometimes they cough it out, which is crazy. Let's see. Look at that. Imagine coughing this out. Like that's crazy. Or even this one. That is a massive blood clot. Okay. For the vital signs, like we mentioned, increased heart rate, respiration rate, decreased blood pressure over time, decreased O2 makes sense. Low-grade fever can also occur just from the body having a struggle, having a large struggle, so your body starts inflammatory response. Could have changes in their level of consciousness or even their urine output, similar to like if someone is going into shock. So that's something you want to assess because they could turn into shock. So what are the first signs and symptoms of shock is the thready pulse, but also a decrease in urinary output because shock involves perfusion and perfusion affects the kidneys and the kidneys will immediately start fighting back and retaining as much fluid as it can to try to keep the blood pressure up. So that would mean less pee. Chest X-ray, it's a pulmonary thing, so chest X-ray makes sense. Can also help to rule out other issues. ABGs could be done, but this is something that's probably going to be dealt with really quickly. But their ABGs will show respiratory acidosis due to poor oxygenation, but initially they can have alkalosis due to having that tachypnea, shortness of breath, so they're hyperventilating initially. Similar to an asthma attack. An asthma attack, they're going to be shortness of breath and all that stuff, so they're hyperventilating initially, but then later on, the oxygenation is not good because it's obstructed, so respiratory acidosis. Here's a picture of the general idea between how alveoli get the O2 exchange. So this is your alveoli. It's full of air and it's right next to the capillaries, so it's going to be exchanging O2 with the blood that way. If you are um, having a pulmonary embolism here, so this is obstruction of the blood flow, you have air, but the blood flow isn't working too good, so you're not having that exchange. A spiral CT can be used to diagnose the pulmonary embolism. So it's basically just a special CT scan. It will use a contrast, so general um, things to be aware of for iodine or shellfish allergies. If you need to do it anyways, you can do Benadryl, IV Benadryl before the contrast. And then there's some extra info here in regards to the kidneys. It's a clot, so clot busters can be helpful. Of course, you're going to be monitoring for bleeding because it's a something that's going to prevent clots, just tear apart clots. So that means if you are bleeding, you're not going to have clots while this is being given. So vital signs, mental status, and bleeding in general, because that's how you're going to determine internal bleeding or outward bleeding. But internal bleeding, the mental status will be one of the first thing you see is going to change his level of consciousness. For anticoagulation therapy, they can be on a heparin drip for the same reason as we talked about prior. The heparin drip can be used to decrease the size, not decrease the size, but prevent the increase of the size of a clot. And again, you're going to be assessing for the PTT. Usually every 6 hours or so, they'll draw the lab to get a PTT, and then the pharmacy will adjust the rate of the heparin drip, and they'll put in an order for you to make the change. And like we talked before, heparin-induced thrombocytopenia is something that can happen. So platelets under 100, you want to make sure it doesn't get to that point. So if you do have platelets under 100, you need to um, call the doctor and maybe pharmacy. If someone's on a heparin drip, you're going to be very careful that they don't bleed. Be very careful when handling them. The antidote, like I mentioned previously, is the protamine sulfate. And something that's nice because this picture's here so you can have a visual is that the IV heparin should be on its own line because you don't want to dilute it with normal saline. And you don't want to dilute it and uh, you don't want a line that had normal saline in it. Just don't want to have that going on. So it just has to be on its own line. So you'll have to, if they need to have IB fluids, they'll have to have them in two separate lines. And just in case, because they can be bleeding, they need to have two IVs or a central line so that in case that they are bleeding, you can do an emergency blood transfusion. Something of note is that when people are going to be placed on Coumadin, Coumadin is slow to take effect. So they will be started on Coumadin at the same time as the heparin if they're going to be put on Coumadin. And they're going to wait for the INR to be for the PT-INR to be at range, like the therapeutic range, and then they'll discontinue the heparin after because the heparin it doesn't last too long when it's given IV. If you disconnect the heparin after a few hours, it will stop taking effect. Your APTT will go back to normal within a few hours. So it stops having an effect very quickly. So you can have them on Coumadin, get the therapeutic, get them off heparin, and then after a few hours, it's like they were only on. It's like right now, it's like they're no longer on heparin. The effects of heparin are not active. But the antidote for Coumadin again is vitamin K, and during emergency situations, fresh frozen plasma can be infused. But I would just focus mostly on the vitamin K, honestly. And some of the same stuff we talked about, because we're doing both weeks at once, some of this overlaps. So same idea, vitamin K intake consistent, preventing things for clotting, so making sure that your blood is less thick, quote unquote, avoiding the G words because they can increase the risk of bleeding. And then same thing we kind of just went over for the DVT is preventing DVT, ambulation, elevation, SCDs, foot pumps, leg massages. If they have a DVT, try to keep it try to keep it still as possible. Try not to manually dislodge it, but I guess elevation's fine. But that was a lot all at once. Just I guess that wasn't as bad. But we also have the other stuff to go over. So I'm not sure how we're gonna do that, to be fair. But I can. Do you guys know if your test will even have pneumonia or COPD, or if it's just like exemplars that you're supposed to like go over on your own? Oh, okay. Okay, that's good. So I know I went super fast over pulmonary embolism. So please tell me if there's anything that you would like more clarification on. Is there anything at all? Because I will make sure that you guys are accommodated on that term. Key difference between pneumonia and pulmonary embolism. Yeah, so, or pneumothorax. Yeah, because they are very vague. It's very similar symptoms. So when somebody comes with all of these these symptoms, having the fast breathing, fast heart rate, pain when they're uh you could usually it'll like I said, there's a spiral CT, so they'll just do a CT of um they can do a CT to kind of like the pneumothorax is diagnosed with a chest X-ray as well. So they'll just run tests. They'll quickly get a CT, X-ray just to see what's going on there and then kind of act immediately. So this person would be in the emergency room if they were like struggling really bad. Usually pneumonia doesn't is not going to have the same severity as pulmonary embolism or pneumothorax. Those are both of those are going to be more like far more severe and acute, while the pneumonia is going to be. Oh, did you mean pneumonia or pneumothorax? You meant pneumothorax, right? You weren't asking about because pneumonia can also have pleuritic chest pain and shortness of breath and all that stuff, but that one's low severity. Pneumothorax and chest and pulmonary embolism are higher severity, but it's through the diagnoses that you're going to be diagnostics that you're going to be t able to tell them apart, and then maybe also from context of like what was going on prior. Sometimes you can have spontaneous pneumothorax. That is possible. Sometimes you can have spontaneous pulmonary embolism. But usually, um, you'll have you will have something like maybe they had a DVT prior, so the pulmonary embolism uh, that would make sense. Like it came from the DVT, or they just got a central line removed, so they have an air embolism, or maybe you'll see on test questions they'll be like patient uh literally had like a femur fracture that they're recovering from, so the fat embolism part of it would for PE, or for pneumothorax it could be that they had a central line placed, so pulmonary embolism from central line removed due to air embolism, or pneumothorax from central line placed and it punctured the lung, or from a thoracentesis, um, for example. So all of that are kind of ways to tell them apart. Um, and then David says hemoptysis only with PE. Yeah, so the coughing of blood is not typical with pneumothorax, but it is typical with pulmonary embolism or a pneumonia. So pneumonia can have like rust-colored. Pneumonia can have like rust-colored sputum. PE will have like actual bloody sputum, or just straight up blood, not even sputum, just blood. And then pneumothorax won't have that. That's another thing that you can use to differentiate. But they are similar. They are very similar. So I would say the main things are context, like the context, like what are the originating factors? Um, like you could say like the hemoptysis, lack of because you might also because you can see here like I guess I took the picture away, but from the picture you can just straight up cough up the clot itself. So let's say those are differentiating factors. So context, the risk factors, and then hemoptysis for that. Uh, and then obviously the diagnostics are going to be important. So chest X-ray, CT. spiral CT. You can do a VQ scan as well. Like this is the VQ scan to see the presence of what's going on. Any other questions? That's a good question. These are all good questions that we had. And I'll just try to fill this out in case, just in case. So pneumonia, chest X-ray for diagnostics, white blood cell count, sputum culture is going to be the biggest one. Maybe an ABG assessment. You're going to have, let's see, respiratory, general. Um, you could do vitals, I guess. Respiratory, cough, dyspnea, tachypnea, chest pain, pleuritic chest pain. Just so we can get it all out of there. Maybe crackles, fever, chills, fatigue, sweating. And you can, when you guys go over tuberculosis, you can go over like, what's the difference between tuberculosis and pneumonia? Vitals, you'll have respiration, high, SATO2, low, possibly lower, hypotension in severe cases. Nursing considerations, encourage liquids to thin secretions. Turn cough, deep breathe. IS usage, monitor O2 and effort. Um, what else? Adherence of vaccines for the elderly. They can get pneumonia vaccines. Educate on hand hygiene and mask use. Suction if needed. Treatment. Antibiotics if it's a bacterial pneumonia. Antibiotics, antivirals. Antifungals if you have fungal pneumonia. O2 support. IV fluids. Fever control. Um, bronchodilators like albuterol to open up the airway. That's pretty much it. So if for some reason you guys need to go over the pneumonia stuff, that should be a good general outline for what goes on with pneumonia. But it is, I guess, only an exemplar that is posted in concept of the day. I swear to God. Let me see. I'll log in and kind of see. And then COPD. You is in I think someone told me you guys already learned COPD. Is that correct or no? Like formally taught COPD as a exemplar? Oh, okay, in 220. All right, cool. So you guys already got that. Oh, perfect. Perfect. Perfect, perfect. So I will just in that case, just I will just copy paste what I have and then just talk about it. Just as a review, but for the most part, you guys are just focused on PE. So I'm just gonna start saving this now so that I can give it to you guys. So, because my internet is running slow, so just so that you guys can start having it and we don't run out of time. Sorry for the rush there. Honestly, I only got like 5 hours of sleep. I went to sleep at like 7 a.m. Uh, let's see. Okay, let's see if I have questions for this one. I do have some questions. Although it might be pneumonia and COPD focused, I'm not gonna lie. But if you want questions, I have extras. Yeah, I think it's mostly COPD and pneumonia, maybe. It is a lot of questions, so if you want practice on respiratory, it still helps. But yeah, so they'll upload. It might take a little bit, which is why I'm just gonna do them one at a time. And then the other two should have uploaded. So as did you guys all get to download the week four and the questions for that? Week five is still uploading. It's slow. Computer slow. Well, my computer's fast, actually. It's the internet that's slow. But yeah, just as that's uploading, um, I'll go down where COPD, cyanosis, they're gonna have a different O2, SAT-O2 range. They're gonna need albuterol to open up the airway, steroids for long-term inflammation. They're gonna be withholding a lot of CO2. They can't get rid of it. Their lungs are gonna be hyperinflated. Hyperinflated meaning that they can have like that's where that barrel chest kind of comes from. So hyperinflated lungs that don't get rid of the CO2, which is why they got to do pursed lip breathing. The pictures are really helpful personally. It just allows me to remember like this guy here. They're in a tripod position. They have a barrel chest. They're pink because with the emphysema, they're breathing so much. With the emphysema, they're breathing so much that they're actually burning a lot of calories just from breathing, which is crazy. I wish I could do that. But they're gonna be pink from the retention of CO2, and then they're gonna be thin because of the effort placed into breathing. So, oh, nice, it uploaded. Okay, and then the questions. Oh, nice, it went through. Okay, but yeah, if you want it review on COPD, it's here. For your exemplar, it's all here. Another thing with the COPD is mucus production. So higher risk of because there's so much mucus production, a lot of it gets stuck in the lungs. So higher risk of infections, respiratory infections. So these people are higher risk for pneumonia, bronchitis, uh, well, infectious bronchitis. So people with COPD can just have chronic bronchitis. So that sucks because I actually had bronchitis not too long ago. It sucks. It hurts to breathe. Oh my God. But yeah, it explains everything here, hyperinflation, the medications that's used, the hypoxic drive. So if you need a refresher on COPD, it's here. Tripoding position. A lot of information here on nutrition because especially with emphysemic people, the fast respirations, the mucus makes it difficult for them to have a meal because they're breathing so much that it's hard for them to get bites in and chew because they're having to breathe so much. And then the mucus can make them not want to eat because they feel like it's nasty to have all that mucus, but they need a lot of protein and nutrition because they're actually burning so many calories from breathing. And then because of that, they're also losing muscle mass, which is why they're so thin, which makes it even worse for them to breathe because if you don't have muscle mass, you're not going to be breathing very well. Uh, and then some complications here with any respiratory condition, or with a lot of respiratory conditions, you can have right-sided heart failure because respiratory condition builds pressure in the lungs. Pressure in the lungs means the blood is backing up into the right side of the heart, backing up into the right side of the heart, right-sided heart failure. But yeah, that's everything. If you guys have questions, the two people that are left, feel free to ask. I'll stop the recording.